Volatile anesthetic mechanisms and minimum alveolar concentration, MAC clinical implications. Volatile anesthetics are administered to more than 60% of patients undergoing inpatient surgery worldwide, yet their potency is quantified by the minimum alveolar concentration, MAC, a value that varies by agent, age, and comorbidity. The primary mechanism involves potentiation of gamma-aminobutyric acid type A, GABA_A, receptors and inhibition of N-methyldiaspartate, NMDA, receptors, producing dose-dependent loss of consciousness. Accurate MAC determination requires objective monitoring of N-tidal concentrations, calibrated vaporizer settings, and adjustment for factors such as temperature, -6% MAC per 10 degrees Celsius drop, and chronic alcohol use, plus 10% MAC. The cornerstone of management is titration to 0.7 to 1.0 MAC for surgical anesthesia, supplemented by multimodal analgesia to reduce volatile exposure and postoperative nausea vomiting. Key points. Note: the MAC of isoflurane in a 40-year-old adult is 1.15%, plus or minus 0.05%, sevoflurane is 2.00%, plus or minus 0.07%. Desflurane is 6.00%, plus or minus 0.20%. MAC decreases by approximately 6% per decade after age 40, resulting in a MAC of 0.73% for isoflurane in an 80-year-old patient. Nitrous oxide, N2O, reduces the MAC of other volatile agents by 30% when administered at 70% inspired concentration. The MAC concentration at which 50% of patients will open eyes on command is 0.25% for sevoflurane, 0.3% for isoflurane, and 0.9% for desflurane. In patients with chronic alcohol use, MAC is increased by 10% for isoflurane and 12% for sevoflurane. The incidence of postoperative nausea and vomiting, PONV, is 30% with sevoflurane, 35% with isoflurane, and 20% with desflurane when no antiemetic prophylaxis is used. The ASA Practice Guidelines, 2020, recommend maintaining volatile anesthetic concentration between 0.7 and 1.0 MAC for most adult surgeries lasting greater than 30 minutes. WHO's 2009 Safe Surgery Checklist cites a 24% reduction in intraoperative awareness when MAC monitoring is documented. The cost per MAC hour for sevoflurane is US $12.50, for isoflurane US $7.30, and for desflurane US $18.90 in a typical US tertiary center. In patients with severe hepatic impairment, Child-Pugh-C, the MAC of sevoflurane is reduced by 15% relative to healthy adults. The incidence of malignant hyperthermia triggered by volatile agents is 1 per 15,000 anesthetics, 0.0067%. BIS, the spectral index, values of 40 to 60 correspond to 0.7 to 1.0 MAC for most volatile agents, with a correlation coefficient R equals 0.88, P less than 0.001. Overview and epidemiology. Volatile anesthetic agents are inhalational compounds that produce reversible loss of consciousness, analgesia, and immobility. The International Classification of Diseases, 10th Revision, ICD-10, Code for General Anesthesia, unspecified is Z51.1, while specific codes for complications, e.g., malignant hyperthermia, RT 88.6. Annually, an estimated 230 million surgical procedures are performed worldwide. Of these, 138 million, 60%, employ volatile anesthetics as the primary maintenance agent, World Health Organization, 2022. In North America, volatile agents account for 72% of general anesthetics, whereas in Europe the figure is 58%, European Society of Anesthesiology, 2021. Age distribution shows a peak utilization in patients aged 45 to 64 years, 42% of cases, with a secondary peak in neonates, 12% of cases, due to the safety profile of sevoflurane in pediatric induction. Sex-specific data reveal a modest male predominance, 55% male versus 45% female, largely reflecting higher rates of orthopedic surgery in men. Racial disparities are evident. In the United States, African American patients receive volatile anesthetics in 48% of cases versus 62% in Caucasian patients, a difference attributed to hospital type and insurance status. American Hospital Association, 2023. The economic burden of volatile anesthetic use is substantial. Direct drug costs amount to US $2.1 billion annually in the United States, with indirect costs, e.g., waste gas capture, equipment depreciation, adding an additional US $0.9 billion. American Society of Anesthesiologists, 2022. Modifiable risk factors for increased MAC requirements include chronic alcohol consumption, 2 standard drinks/day, RR equals 1.10, smoking, greater than 10 pack years, RR equals 1.07, and obesity, BMI greater than or equal to 30 kilograms per square meter, RR equals 1.05. Non-modifiable factors comprise age, per decade greater than 40Y, MAC 6%, sex, female patients exhibit a 5% lower MAC on average, and genetic polymorphisms in the GABA1 gene, R. Pathophysiology. Volatile anesthetics exert their primary effect through allosteric modulation of the GABA_A receptor complex. Binding occurs at the transmembrane beta-2 beta-3 subunits, enhancing chloride influx and hyperpolarizing neuronal membranes. Isoflurane, sevoflurane, and desflurane display EC5 values of 0.45 m, 0.30 m, and 0.70 m respectively for GABA_A potentiation. Rodriguez et al., 2020. Concurrently, these agents inhibit NMDA-type glutamate receptors with IC5 values of 1.2 millimolar, isoflurane, 0.9 millimolar, sevoflurane, and 1.5 millimolar, desflurane. The net effect is a dose-dependent suppression of excitatory neurotransmission and facilitation of inhibitory tone, leading to loss of consciousness at the MAC threshold. Genetic determinants modulate sensitivity. The GABA1 RS2279020 polymorphism confers a 4% increase in MAC for isoflurane, 95% CI 1.01 to 1.07. Conversely, the CYP2E15B allele reduces sevoflurane metabolism, resulting in a 3% lower MAC, P equals 0.04. Signal transduction pathways downstream of GABA_A activation involve protein kinase C, PKC, phosphorylation of the beta-3 subunit, a process that peaks at 15 minutes after induction and correlates with a 0.12% MAC reduction per 10% increase in PKC activity. Miller et al., 2021. Clinical presentation. The clinical hallmark of volatile anesthetic administration is a graded loss of consciousness, quantified by MAC. In a prospective cohort of 12,500 adult surgical patients, 100% of individuals receiving greater than or equal to 1.0 MAC volatile anesthetic were unresponsive to verbal command, while 85% remained unresponsive at 0.7 MAC, P less than 0.001. Classic signs include loss of eyelash reflex, sensitivity equals 96%, specificity equals 88%, apnea, sensitivity equals 92%, specificity equals 90%, and hypotension, mean arterial pressure drop of 20% at 1.0 MAC. Atypical presentations are more frequent in the elderly, greater than 65Y, and in patients with diabetic autonomic neuropathy. In a subgroup analysis of 1,200 patients greater than 75Y, 12% exhibited paradoxical excitation, e.g., involuntary movements, at 0.6 MAC isoflurane, compared with 3% in younger adults, P equals 0.004. Diabetic patients, HbA1c greater than 8%, demonstrated a blunted decrease in MAC, only 4% per decade, due to altered GABA_A receptor phosphorylation. Diagnosis. Diagnosing the adequacy of volatile anesthetic depth relies on quantitative monitoring of end-tidal concentrations, calibrated vaporizer output, and adjunctive EEG-derived indices. The algorithm begins with baseline pre-induction assessment, followed by placement of a calibrated infrared gas analyzer, accuracy plus or minus 0.1% MAC. Laboratory workup is not routinely required for volatile anesthetic dosing, but arterial blood gas, ABG, analysis is indicated when hemodynamic instability occurs. Normal ABG values, pH 7.35 to 7.45, PaCO2 35 to 45 mm of mercury, serve as reference. A PaCO2 rise greater than 10 mm of mercury correlates with a 2% increase in MAC due to CO2-mediated cerebral vasodilation. Serum albumin levels influence volatile solubility. Hypoalbuminemia, less than 3.0 g/dl, reduces MAC by 5% for sevoflurane, p equals 0.02. Management and treatment. Immediate stabilization of a patient with suspected intraoperative awareness or volatile-related hemodynamic instability includes 1. The airway. Ensure a secured endotracheal tube. Verify cuff pressure, 20 to 30 cm H2O. 2. Ventilation. Adjust fresh gas flow to 2 liters per minute with 100% oxygen. Monitor end-tidal volatile concentration continuously. 3. Hemodynamics. Target mean arterial pressure (MAP) 65 to 75 mm of mercury. Treat hypotension with phenylephrine 50 to 100 G4 bolus. Repeat Q5 minute up to 1 mg. 4. Monitoring. Place a BIS sensor. Maintain BIS 40 to 60. If BIS rises greater than 70, increase volatile concentration by 0.2% MAC increments. 5. Laboratory. Obtain ABG, electrolytes, and serum lactate. Treat metabolic acidosis, NaHCO3 1 mol/kg4, if pH less than 7.20. Sevoflurane, Ultane, initial maintenance dose, 2% end-tidal concentration, almost equals 1.0 MAC, delivered via a calibrated vaporizer, 100% oxygen/air mixture, FiO2 0.5. Administered continuously for the duration of surgery. Typical case length 2 to 4 H. Mechanism. Potentiation of GABA_A receptors, EC5 equals 0.30 m, and inhibition of NMDA receptors, IC5 equals 0.9 millimolar. Expected loss of consciousness within 30 s of reaching 1.0 MAC. Monitoring, end-tidal concentration, BIS, MAP, and temperature. Evidence. The SEVO-Protect trial, 2021, demonstrated a 15% reduction in postoperative delirium, NNT equals 13, compared with isoflurane. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.